Okay, I'll start. Right, does everybody see my screen yet? Hello, Assalamualaikum. Hello, can everybody hear me and you guys see my screen? Wonderful. Okay, so I'll start now. Okay, so today's class will just be a continuation of our last class. I hope everybody has attended the class, and who hasn't, I hope that you've watched the recording. Okay, I'll just briefly go over what we discussed in the last class, and then I'll take it from there. So you all know this is Dr. Salman Rashid. He's a founder of SMLE Guide. He's here with us today, but I'll be the one speaking on his behalf. Right. So when it comes to ECG, we know that ECG stands for electrocardiography, which just means we record the electrical activity of the heart and we present it graphically on a piece of paper. That piece of paper is known as an ECG tracing, right? And there are a number of things that are happening in the ECG, a number of cardiac events, and you need to know what each of these tracing represents. For example, let's take this. This is your basic ECG tracing. The P wave, as I discussed last time, stands for atrial depolarization, right? And I hope everybody remembers that. Um, just a minute. I don't see anybody's comments, so I'll just join from my phone. 1 minute. So I can see if people have any doubts or anything. Second.
Live streaming is on.
Right. Okay, if you guys. Just a second, I'm sorry. Okay.
Live streaming is on.
Yeah. So if any of you, is my voice still echoing? Or is it okay now? Hello? Yes, it's okay, right? Okay. So if you have any doubts, you can just go ahead and write it in the comment box. So if you remember last time, I explained that the P wave is representative of what? Atrial depolarization. And then we have a certain PR segment, which is an isoelectric line, and this is when atrial repolarization is happening, but it's a very, very small electrical activity, so the ECG machine does not pick up anything, and hence we have no deflection, whether positive or negative. Okay? Then comes the major chunk of your ECG, which is the QRS, and Q, if you remember, is what? Ventricular depolarization, but which part of the ventricle is being depolarized? The septal part, right? So Q represents the ventricular septal depolarization. R is the major chunk of the ventricle being depolarized, and S is what? The base of the ventricles being depolarized. So overall, if you talk about the QRS complex, you're literally talking about the ventricles undergoing depolarization. Okay. And then comes this SC segment. This is when the entire ventricular tissue is depolarized and hence there is no net movement of charges. No net movement of charges means there is no net deflection and hence the ECG machine does not pick up anything. Um, yeah, okay. And then we come to, can everybody see my screen? Hello? Yes? Okay, so then we come to T wave, which is the ventricular repolarization. This happens when the entire ventricular tissue is depolarized, and the last point to depolarize is also the first point to repolarize. So the T wave, which is a positive deflection, again represents ventricular repolarization. Okay, so everybody knows what I'm going to talk about. Now, what we're going to do today is take it a step ahead. I want to teach you all how to read this basic ECG and identify certain conditions that you might have, abnormal conditions, right? Abnormal ECGs. So, first thing, before I jump into that, when you're recording an ECG, there are different ways to record an ECG. Like there is a 12 lead ECG, there are defibrillators, there are certain other cardiac monitors. When you really want to know what's happening with the patient, remember that the ideal thing that you would go for is a 12 lead ECG because it looks at the heart through different limb leads and through different angles. And to identify a certain problem, you need to look at the heart from it. You need to have a 360 view. You get me? Which is why your go-to ECG anywhere would be a 12 lead ECG, unless you're working in the A&E and you have no time and the person is in cardiac arrest. Then you just use the defibrillator pads to identify the rhythm and then to go and address the rhythm that you're saying. ओके मेरी इतनी बात क्लियर है कि देर आर डिफरेंट फॉर्म्स ऑफ different ways to identify the ECG tracing. You can have different cardiac monitors. You can have a three lead ECG. You can have a 12 lead ECG. You can have a 6 lead ECG. You can use a defibrillator pad. But your ideal ECG tracing should be with a 12 lead ECG. Okay, why? Because 12 lead ECG में we have 12 leads. It's looking at the heart in the vertical plane, horizontal plane. आपको एक 360 view मिल रहा है, so you can identify the condition properly. Okay. Starting with the very basic, the first cardiac monitor that I will talk about is a three lead ECG, and what we do is it's standardized. Red represents the right arm. That is where you put the red lead on the right arm. Yellow, this is just for mnemonic, so it's easier for you to understand, on the left arm, and green for the leg lead. Okay. Now I have a very simple question. When you're placing the leads, where do you think you should be putting the leads? Over the bone or over the muscles? Guys, you can go ahead and type in the chat box. Over the muscles. Dr. Fatma says muscles. Everybody else, what do you think? When you are placing the ECG leads, where do you think you should be placing the pad? It should be okay. Salman says muscles as well. Dr. Madia says muscles. Okay, everybody, interact. Talk to me. Tell me why do you think it's muscles? Muscles. Okay, I'll just pick one of you. Dr. Shahzeb, can you tell me why do you think it should be muscles and why not bone? Exactly, please don't sleep. Talk to me, people. So, Dr. Shahzeb, you said it's muscles, right? Could you just like I want to understand why do you think it's muscles? Okay, Dr. Fatma says it can be transmitted through muscles. Okay, so now the answer is that it should be placed over a bone. Dr. Fatma, you do have a point, but remember, ECG is what? Electrical activity of the heart, right? आपकी electrical activity is conducted, and you have a tracing. It is conducted via what? The skin. So even if you place it over the muscle or the bone, both of them are conducting the electrical activity, and what's really bringing it to the surface is your skin, right? Even a bone is a conductor. Why you should be placing the ECG pad on the bone is because there's something known as a muscle artifact. Muscle में you remember there's so much depolarization, repolarization, action potentials happening, right? तो अगर आपने ECG की जो pad है उसको आप लगाते हैं muscle के ऊपर, it can record an irregular abnormal tracing for you. Do you understand me? लेकिन bone में there is no such thing happening, right? To avoid all these muscular artifacts, abnormal readings, false results, you always place it over the bone. Am I clear? It's a very simple point, but I just put it up so because I think it is a good point. We should be knowing it, right? So when we're talking about the three limb ECG, I told you the positions. Right, red is for the right arm, yellow is for the left arm, green is for the leg. Now, let's say you're in an emergency situation and you don't have time to put up the 12 lead ECG and the patient is in cardiac arrest, not responding to you, unconscious. What will you do? First thing that you need to do is, of course, shout for help, you'll call help, and you'll put on the defibrillator pads. Defibrillator is basically a device that allows you to give a shock Okay, but before you give a shock you need to remember कि हर rhythm जो होता है it's not shockable. Not every rhythm that the defibrillator or the ECG shows you is something that you can give a shock for. And if you do give a shock for a rhythm that's unshockable, you're literally not doing anything but causing pain to the patient, right? So first thing that you need to do is put on the defibrillator pads so you identify what is the rhythm that's happening, and then you correlate that rhythm to the patient's clinical picture. You don't just read the rhythm. Let's say I see a VF on the defibrillator monitor. Will I just go in shock? Of course I will, because VF needs a shock. But if there is a certain rhythm and clinically the patient is still somewhat okay, you need to you need to put both things into picture. You need to look at the shock, the rhythm, as well as the patient's clinical condition, and then give a shock. Okay? So the defibrillator pads, and they're also used as ECG monitoring in emergency situations. That is my point. Okay? Now, where do you put the defibrillator pads? You have two pads. Where would you put them? Bone, muscle, what would be the positions? Anterior, posterior? What would you do? Anybody who's worked in an emergency or has ever done a defibrillation, do you know where you put the pads? Okay. Nobody? So defibrillator, like I said, we have two pads. The first pad would be here. If you're seeing my screen, yes. Dr. Soha said anterior. Would you put both pads in anteriorly, or could you put one pad on the posterior side of the patient? Dr. Soha is right. The pads are supposed to be interior, but in some conditions you do put one pad in front and one pad at the back of the at the patient's back, like right at the back. Okay, but usually your pads की position है, one is here. If you're seeing my screen, one is under the your your right clavicle, again over the bone, and the other would be in the left underarm area in the anterior axillary line. Okay. And remember, because this is a defibrillator pad, you need to make sure once you put on the pads, you never touch the patients. You literally would fail your ACLS training if you do not move away oxygen, if you do not move away your colleagues, if you do not like ask everybody to step back. Why? Because the moment you identify the rhythm, you need to shock. And if there is somebody who's in direct contact with the patient, they will also get the shock. So when you put on the defibrillator pads, one thing you do is it's hands free. You need to move away. You need to instruct everybody to move away. You've done putting the pads, then you see the rhythm, and then you shock the patient. Okay? Yeah. Let's go ahead. So these are 6 simple steps. I'm sorry if you hear cats crying. It's because नीचे बहुत ज़्यादा बिल्लियाँ हैं वो they are always crying. So yeah. Sorry if that's bothering you all. Okay, so there are 6 steps to read the ECG, and I think this is the easiest way to really get to any ECG. Whenever you see a rhythm strip, right? First thing, don't panic. Then ask yourself these 6 questions, and by the time you reach the fourth question, you'll be able to identify almost 80% of the rhythms. Okay? And you don't have to be very like meticulous. You don't have to really like cry over कि जी इसका आंसर मुझे मिल रहा है या नहीं. Just a rough idea, like a rough estimate. ठीक है? So when you're looking at an ECG strip, first thing is you ask yourself, is there electrical activity? What do I mean by this? अब मैंने आपको एक random ECG strip दे दी है, ठीक है? Let's open this. This is my ECG strip. Oh, you see, yeah, this one. We'll talk about this. Sorry, we'll talk about this. ठीक है? So do you see electrical activity, people? Do you see any electrical activity? Yes or no? Hi, is everybody with me? Okay. Right, you see electrical activity, right? No, no, don't tell me what's the rhythm. I don't want to know the rhythm. I just want to know, do you see electrical activity in this tracing? Very good. You do. What is electric? When I say electrical activity, I'm literally just trying to ask you, do you see any tracing? If you see any tracing, definitely what does this mean? That there is some sort of electrical activity, right? है ना? वरना तो ट्रेसिंग है होगी ही नहीं. If there is no electrical activity, the ECG would show nothing. Or maybe the ECG is not connected to the patient. So if you see no tracing here, it could be because maybe the pads are not connected to the patient. Maybe the pads are not connected to the patient, or maybe the machine is not properly turned on, right? So जैसे ही आप एक ECG strip देखते हैं, first ask yourself, is there any electrical activity? Great, there is. Sure. If there is no electrical activity, this is an example of no electrical activity. First thing you do is go back and check. Okay, why is there no electrical activity? Could there be a possibility that the ECG pads are not connected to the patient properly, or the machine isn't turned on? Once you're sure कि machine on है, the pads are connected right, the pads are placed properly, then the first question is done. आपको पता है कि हर चीज़ right है, कोई tracing ही नहीं आ रही, तो probably the patient is in asystole, right? Yeah. And this solves the first scenario, which is asystole. और इसका ये मतलब है asystole literally means that the patient is dead. Okay. तो अगर आपको ऐसी, this is what you're finding, this means that you've lost the patient is dead. And never expect asystole to be this way. Never expect a straight isoelectric line. Why? Because I remember a person, imagine a person with an acute coronary syndrome, ACS. Maybe he had VF, और उसके बाद आपका monitor started showing this. ठीक है? So do you think you're still doing CPR, you're doing chest compressions, the patient still like there's some sort of manual blood circulation happening? Do you think the asystole line would be a straight isoelectric line? Nahi. Of course, the heart is still pumping. There would be some cardiac output. Some things would still be happening. The person is still dying. So it would be like this. Asystole, what I mean is, it wouldn't be a straight isoelectric line. It would somewhat be undulated. थोड़ी सी है, some sort of activity still happening until the patient is completely gone. ठीक है? So if this is what you have in your SMLE, then this is asystole. Clear? If you see an isoelectric straight line, then you probably need to go back and check whether the monitor is connected properly or not, or if the machine is working fine or not. Yes? Coming to the second scenario, it's not important, but I'll just go over it. This is something as P wave asystole. If you see, you're still having P waves, right? You still have P waves. But what you don't have is a QRS complex, right? And that's my first scenario. So what you do is, P wave means there is some sort of atrial activity. But what we are not seeing is QRS. Yani ventricles are not working. The ventricle is in asystole or ventricular standstill. Why do you think this scenario is important? Why do you think I put up this picture? Because यहाँ पे the heart is still working, P wave की activity still means that there is some sort of atrial activity, yes. QRS नहीं आ रहा means the ventricles are not working. What you need to do is, since the heart is still working, you need to start pacing. And once you start pacing, most probably you will be able to achieve some sort of cardiac output. Okay? Unlike in an asystole में अगर आप करें भी pacing, nothing is gonna happen. And by the way, pacing जो होती है उसके लिए you need, you know what's a pacemaker, right? You know what's pacing. Pacing is when you put up a device and then you literally are helping the heart beat again. ठीक है? Externally. और pacing के लिए हमेशा, मैं आपको आगे pacing की spike दिखाऊंगी. You always need to start somewhere. You always need to have some sort of ये activity, वरना आप पेसर काम ही नहीं करता. Pacing कैसे होती है? It has to identify, for example, a P wave, or has to identify a QRS complex. अगर कुछ है ही नहीं तो पेसर चलेगा ही नहीं. So asystole में you can never pace it because you don't have any sort of activity to start the pacemaker. No rhythm is identified. Rhythm ही नहीं है, so the pacemaker doesn't work. This still has a P wave. So once you put up a pacer, you still can get some sort of cardiac output. ठीक है? But still, this is an asystole. Right? Everything clear so far? Anybody has any doubts, please ask me. Everybody, do you guys have any doubts, any issues, any concerns, or asystole is clear for everyone? Very good. So the first question that you asked yourself was, is there any electrical activity? Once you see that there is no electrical activity, probably you're thinking of asystole. But you just have to always make sure that the leads are connected, and the ECG is working properly. Yes, Dr. Kriti, please go ahead. P wave. So this is still an asystole. It is an asystole. The patient is dead already. Okay? Or the patient is dying, you can say. But you're still seeing a P wave, right? No QRS means no ventricular activity. P wave means there is some sort of atrial activity, but eventually it's going to become like this. Okay? If you see a P wave, you can try pacing. The patient isn't really dead, but the patient is dying because the ventricles have stopped working. So you can try pacing using this, and you might be able to achieve some sort of cardiac output. Unlike in a complete asystole, pace ही नहीं कर सकते उसको. Do you understand my point? That asystole could be complete loss of everything, which is the most common thing that you see in the clinic. Or you could see some sort of P activity, but don't, just because you see a P wave, don't think this is not asystole. It is still asystole because you don't have a ventricular complex with it. So what you do is you try pacing. If it works out, it works out. If it doesn't, it's eventually going to turn into this in a few minutes. Yeah. Okay. The second scenario is so now if you don't see any electrical activity, your answer is no. The first question was, do you see any electrical activity? The answer is no. You check the pulse, no pulse, of course. This is asystole, and that was the first scenario, and it's done. Or you could have a P wave asystole, which is almost the same thing. Again, no pulse. You'll still try pacing. हो गया तो हो गया. Otherwise, you've lost the patient. Okay. Now, there's what happens is that, and ask yourself the same question again: is there some sort of electrical activity? And this time, I'm saying yes, there is an electrical activity. Okay, and the electrical activity is like really bizarre. It's very irregular. बहुत ही अजीब सी डरावनी सी ECG है. And this is one the most important scenario which you should be scared of. VF is an emergency. You need to identify the VF, and you need to treat the VF. Okay, and one clinical pearl for all of you. Remember, a patient with VF will never be conscious. You will never find a patient in VF who is vitally stable or awake. Because if the patient has a pulse, if the patient is awake, the patient is not in VF. ये बात आपने हमेशा याद रखनी है. जब अब SMLE में भी वो आपको ECG दे रहे हैं, right? They will always put up a question stem, right? Please read the question stem as well. If you see that the patient is awake, if you see that the patient is conscious, if you see that the vitals, the patient is vitally stable or somewhat near stable, don't choose VF as your answer. It is always going to be wrong. Okay? Why? I will talk about it now. Okay? So the first question, when you said, is there any electrical activity? No, that was an asystole. Now I'm saying yes. The answer to the first question was yes. There is an electrical activity, but it looks like this. Something really bizarre and weird. Okay? But patient has no pulse. Right? Okay? So this is what you see. This is ventricular fibrillation. Patient will not be awake. Patient will have no pulse. You have to go and treat the patient as soon as you can. It's a medical emergency. Your most important abnormal rhythm. इसको address करना बहुत ज़रूरी, right? अब ventricular fibrillation की these are like certain specific details. There are so many things that I can talk to you about ventricular fibrillation. I won't really go into details, but मैं आपको सिर्फ बता रही हूँ. This is the rhythm that you see. Both of these are cases of ventricular fibrillation. This is coarse. It's a very harsh pattern, right? So this is coarse ventricular fibrillation. You won't really have to differentiate between coarse and fine ventricular fibrillation. Just look at the pattern and know what's happening. कोई ना पी वेव तो है ही नहीं, और क्यू आर एस भी हम आइडेंटिफाई नहीं कर सक रहे. सो द वेंट्रिकल इज बीटिंग so fast that there is no recognizable cardiac rhythm. Okay, why am I saying the patient is unconscious? Because the ventricle is beating in such a bad manner कि कोई cardiac output है ही नहीं. So because there is no cardiac output, imagine there is no blood going to the brain, no blood going to the brain, the patient is hypoxic, the patient is unconscious. You get it? इस rhythm के साथ कभी भी you will never find an awake patient. Yes? Is everybody with me so far? So ventricular fibrillation is one of the most severe, horrible patterns you can have, and it will never happen in an awake patient. If you see a pulse, if you see the patient is awake, please exclude ventricular fibrillation from your options. Right? This is just to tell you the difference between coarse and fine ventricular fibrillations. The treatment is the same, everything is the same. You don't have to bother about it. Okay. Now I said that पहले question का third scenario. So first question we asked ourselves was, is there any sort of electrical activity? पहले हमने कहा नहीं है. So we got into asystole. We solved asystole. One mystery is done. Second thing we said was, yes, we have electrical activity, but it's really weird and the patient is unconscious. This is probably a VF. Okay. Third scenario is that you see electrical activity. Again, the answer is yes, but there is no pulse. Again, you see electrical activity and there is no pulse. And when I say you see electrical activity, I am not trying to tell you कि you see VF. नहीं, ये जो electrical activity है, it's like, so you're just expecting that there is some sort of this is not, by the way, this is pulseless electrical activity. So there is electrical activity here, something is happening, but there is no pulse. Now, what am I trying to tell you? That electrical activity is happening, but it's not good enough, it's not nice enough to give you some sort of mechanical contraction in the heart. ठीक है? और ये जो इलेक्ट्रिकल एक्टिविटी है, इसको आप किसी भी रिदम में आइडेंटिफाई नहीं कर सकते. आप ये नहीं कह सकते कि ये वी एफ है, ये नहीं कह सकते कि ये ए एफ है, ये नहीं कह सकते कि ये सुपरमेटिकुलर टैकीकार्डिया है. यू जस्ट डोंट आइडेंटिफाई इट. तो ऐसी कोई भी इलेक्ट्रिकल एक्टिविटी विच डज नॉट रियली रिजेंबल एनी अदर पैटर्न, विच डज नॉट रियली रिजेंबल लाइक अ वी एफ, ए एफ, कुछ भी, एस वी टी, राइट, उसको हम पल्सलेस, फ्रॉम द नेम पल्सलेस इलेक्ट्रिकल एक्टिविटी कहते हैं. ठीक है? The moment you see pulseless electrical activity, जहाँ पे आपने देखा कि there is a pulseless electrical activity, start CPR. Why? Because you're literally trying to resuscitate the heart and the lungs to produce what? Pulse. Once a patient has pulse, you can bring the patient back and you can actually make the heart beat normally again. Got me? So, पहला question, I'll revise this. The first question you ask yourself, is there any electrical activity? The answer is no. Patient is in asystole, but you just have to confirm that the leads were properly placed and the machine is working. ठीक है? Asystole हो गया. Second thing was that it is an electrical activity. Yes, it is, but it's really weird, scary, creepy, and the patient is unconscious. This is ventricular fibrillation. Has to be treated then and there. It's a shockable rhythm, so you go and you address that. ठीक है? Then there is another scenario. Yes, it is electrical activity, but मैं identify नहीं कर सकती हूँ कि electrical activity क्या है. I cannot classify this as VF, AF, SVT, nothing. There is electrical activity, there is no pulse. Whenever I see electrical activity, first thing what you do is you go and check a pulse. Why? इसलिए हम पल्स चेक करें, टू आइडेंटिफाई पल्सेस इलेक्ट्रिकल एक्टिविटी. तो जब भी हम डिफिब्रिलेटर पैड ऑन करते हैं, ठीक है, और हम देख रहे हैं कि ओके देयर इज अ ट्रेसिंग, गो एंड चेक द पल्स. गो मेक दिस अ हैबिट, गो चेक द पल्स. अगर पल्स नहीं है, दिस इज PEA, एंड द गुड न्यूज़ इज दैट यू कैन एक्चुअली सेव अ पर्सन इन PEA. हाउ? बाय स्टार्टिंग CPR immediately, effective chest compressions and breathing. You can actually bring the patient back and you will see कि rhythm जो है वो या तो convert हो जाएगा VF में, AF में, something will happen and you will be able to identify this rhythm then. ठीक है? Yes. Everybody with me so far? Got so far? Okay. Then the fourth scenario, which is the easiest scenario is that you see electrical activity and you can see good activity. You see P, you see QRS, you see T. Of course, this is what you want. It looks like a normal ECG. Then it's time to move on to your second question. ठीक है? Right? So your second question that you need to ask yourself is, what is your QRS rate? Now this is something really easy, but it's a confused karna is super hard. We get, me myself, I get so confused so many times. But once you really understand how to calculate the rate, and I think I'll do this at the end of the lecture if you want, or maybe we can do it now, whatever you guys say. So once you know how to calculate the QRS rate, you can literally tell yourself, okay, we'll do it now. Okay. So ventricular rate, normally the heart rate, should be from 60 to 100 beats per minute, right? If it is less than 60, you're talking about a bradycardia. If it's more than 100, you're talking about a tachycardia. So second question say you will be able to identify whether the patient has a tachyarrhythmia or a bradyarrhythmia or not. Right? A patient could have a normal ECG, electrical activity है, yes. Ventricular rate is 60 to 100 के बीच में, perfect. You move on to question number 3, right? But in the second question, if you see that somebody has a heart rate less than 60, this is a bradyarrhythmia and this is another huge chunk we need to talk about. Or this is a tachyarrhythmia and there is so much you need to speak to. I need to speak to you about tachyarrhythmias. ठीक है? तो पहले तो ये पता लगाना है कि how do you actually identify the QRS or the heart rate. QRS rate is what is your heart rate, right? Remember last time अगर मैंने आप लोगों को समझाया था, sorry this is for myself, I'll just add another or I'll just zoom in so I don't waste time drawing it again. So this is your ECG strip, ठीक है? My drawing is horrible but yeah. These are your boxes. ये आपके ECG boxes हैं. If you remember last time I put up an ECG machine like this, I put up a galvanometer, I put a needle, and I told you there is a stand and the ECG strip is moving like this, right? Of course now the ECG strip is moving, so there must be a speed that the ECG strip is moving with, right? Remember the speed, the standard speed of an ECG machine is 300 big boxes move in 1 minute. So when the strip moves, in 1 minute you will literally have 300 boxes moving, then 300, then 300. That's the speed. Uh, right? So that's the speed of your ECG, which is 300 big squares in 1 minute. Right? So we literally mean there are 300 big squares in 60 seconds. Okay? Now remember, if I want to find out if 300 big squares move in 60 seconds, how much time does one big square take to move? So what will I do? I'll divide 60 over 300 and I'll get is 0.2 seconds. So in 0.2 seconds, one big square moves ahead. And in 1 minute, 300 big squares move ahead. Easy? Does that make sense? So when you're talking about an ECG strip, you need to know the speed of your ECG strip. The speed of your ECG strip is 300 big squares moving in 1 minute or 300 big squares moving in 60 seconds. I want to know how long does a big square take, like one big square take to move, and that would be 0.2 seconds. Right? Simple? Or you're still confused? Hi guys. Clear, right? Okay. So remember also, this is your big square. Every big square has 5 small squares. So 1, 2, 3, 4, 5, right? One big square we are saying is moving in 0.2 seconds. I want to know what does one small square, how long does one small square take to move? So what will I do is, one big square has 5 small squares. One small square is going to, this is the time for one big square to move. I have 5 small squares. I'll divide it and I'll see that every 0.04 seconds, every 0.04 second, one small square moves ahead. Right? Good. Understandable. तो अगर मैं आपसे कहूँ one small square represents 0.04 seconds, one big square represents 0.2 seconds. Good guys? Clear? Can you repeat? Right, okay. So I'll come back. Your second question is that you need to ask yourself, what is the ventricular rate, which is what is your heart rate? Okay. Normal heart beats at a rate of 60 to 100 beats per minute. Okay. So anything below 60 is a bradycardia, anything below above 100 is a tachycardia, and we have abnormal ECGs where we have bradyarrhythmias and we have tachyarrhythmias, and we need to speak about them. But first, I want you to identify the heart rate using the rhythm strip, using your ECG strip. Okay? Which is why I'm explaining all this. Okay? So I said that ECG is basically a graph and it's moving at a certain speed, right? You need to know what is the speed of that graph. How fast does that graph move? How can you understand this? Remember, keep this in your mind. Every 1 minute, 300 big squares will move ahead. Every 1 minute, 300 big squares will go forward. Okay, right? So in each minute, 300 big boxes are going to move ahead, right? Or you can say 60 seconds, 300 big boxes, 300 big squares will move forward. Okay, now if I want to identify how long does one big square take to move ahead, what will I do? I will literally take 60 divided by 300, I will get 0.2 seconds. So 0.2 seconds is the time that one big box takes to go ahead. So one big box is literally equivalent to 0.2 seconds. This is what I'm trying to tell you. Okay? Now every big box also, remember, has 5 small boxes. If you see in the ECG strip, you'll see that there are bigger boxes and there are smaller boxes. Every one big box has 5 small boxes. I told you one big box is equivalent to 0.2 seconds. So how much would be one small box? You divide 0.2 by 5 and what you get is 0.04. So a big box is equivalent to 0.2 seconds. A small box is equivalent to 0.04 seconds. Is that clear? Why am I telling you this? I will tell you. You will understand. You need to know what is one small box and what is one big box. Because every P, QRS, there is a certain normal limit for them. Like P is atrial depolarization. It is supposed to happen over 2.5 squares. This is what I've written. P is supposed to happen over 2.5 squares. 2.5 big. Yes, small squares. ये मेरा आपसे सवाल है. 2.5 small squares. ठीक है? 2.5 small square. Each small square is 0.04. I said 2.5. So 0.04 plus 0.04 plus 0.02. P. Atrial depolarization is supposed to happen over 0.1 seconds. So imagine that atrial depolarization का entire process from the time that the SA node fires until all the atrial tissue is depolarized, it's supposed to take place within 0.1 second. Got it? So if you see atrial activity for like 0.3 seconds, is it normal? No, because normal atrial activity is supposed to happen over 2.5 small boxes, which is 0.04 plus 0.04 plus 0.02, which is equal to 0.1 second. आपकी सारा atrial tissue is depolarized in 0.1 second only. Right, people? Okay. Now, after the P wave, what you have is, this is your P wave, and then there was a segment, an isoelectric line. This, the P wave happens over, abhi main bol rahi hu, P wave happens over 0.1 second, 2.5 boxes. I will just make this very easy for you. Next activity is also 0.1 second. Atrial repolarization, which you don't see on an ECG, is also 0.1 second. Remember, this is 2.5 boxes, and this will also be 2.5 boxes, means one big square has P wave, and it has what? This segment, right? It has this isoelectric line, और यहाँ से QRS start हो रहा है. Do I make sense to you? That P atrial depolarization is supposed to happen in 2.5 boxes. First one, this has, every big square has how many small boxes? 1, 2, 3, 4, 5. 1, 2, 5. Okay, so imagine these are my 5 boxes. Every P activity is supposed to happen in 2.5. Okay? P is supposed to happen in 2.5. Remaining 2.5 will be your isoelectric line, and then you will have the QRS. So in one big box, you will have, first half will be P, okay, and the second half of this big box will be an isoelectric line. That is where the atria is repolarizing. Yes? Clear? Simple? Does everybody understand? Dr. Kriti is the only one who's talking to me. Where is everybody else? Yes? Guys, interact, talk to me. So, one big box, yeah. One big square is 0.2 seconds, one small square is 0.04. The more you repeat this, the easier it would be to understand. Okay, Dr. Fatma, I'll repeat it again. So, every ECG has a certain speed. The ECG strip moves at a certain speed, right? What is the speed? This is a rule. Just take it, keep it in mind. Standardized ECG strip moves at 300 big squares in 1 minute. Okay? Or I can say 300 big squares in 60 seconds. Right? Okay? Now, if I'm saying 300 big squares in 60 seconds, how much would a big box take? One big box take. How much time would it take? I would literally just divide 60 over 300 and I would get zero point 0.2 seconds. So one big box will take zero point 0.2 seconds to move ahead. Okay? Now I know that every big box has 5 small boxes, right? So this big box has 5 small boxes. I want to know what is the time taken by this small box to go ahead. You can't see my screen? Dr. Sohanur, you can't see my screen? Is it blur or you don't see it? Hi. Okay. I hope you see it now. So takes one small box takes 0.04 second. इतना हमने समझ लिया कि one big box will take 0.2 seconds, one small box will take 0.04 seconds to move forward. So one small box is equivalent to 0.04 seconds and one big box is equivalent to 0.2 seconds. Why you need to understand this is because you need to know if the activity that you're seeing, whether it's P, Q, RS, segment, interval, whatever you're seeing, is it normal or is it prolonged or is it too less? So you need to identify this. So if you don't really know what a normal activity should be, you will never know what abnormal looks like. Okay. So here when I tell you P, this one, sorry my drawing is disgusting, but when I tell you P, a normal P should be 2.5 small squares, 2.5 small squares. Every small square is 0.04. 2.5 means 0.04 plus 0.04 plus 0.02. So a normal P wave should cover 2.5 small squares or 0.1 second. If somebody asks you how long does atrial depolarization take, literally 0.1 second. Understand? Yep. Clear, guys? That was my last point. That if somebody asks you how long does an atrial depolarizing event take, literally 0.1 second. And how would you represent it on an ECG strip? With 2.5 small boxes. And to make things easier, P wave के बाद क्या आता है? There is an isoelectric line, right? Atrial repolarization, but the ECG does not pick up anything. PR, exactly. ECG जो है उसे pick up नहीं करती. Also, PR is 0.1 second. वो भी 2.5 boxes हैं. So 2.5 plus 2.5, 5 boxes बन गए ना? Small 5 boxes, right? 5 small boxes is equivalent to one big box. So your atrial depolarization and repolarization literally can be represented in one big box. That's my point. Pehla second 2.5 boxes would be the depolarizing event, and this next 2.5 would be atrial repolarization, which is PR interval. It's an isoelectric line. Why? Because जो atrial repolarization, if you guys remember, is a very small current. उसका vector नहीं बनता, so the ECG does not pick up anything. All the newcomers, please don't be confused. Go back to the video about these vectors and how to build the ECG, and you will really understand what I'm trying to say. ठीक है? So atrial depolarization happens in 2.5 squares, 0.1 second. The next event is PR, which is also 0.1 second. The remaining 2.5. So one big box would represent your entire atrial depolarization to the atrial repolarization. Clear? Simple. Very good. So next we move on to QRS, right? Okay. Now the QRS again, also very easy to understand. QRS should happen over 2.5 small squares. So pehla event atrial depolarization 2.5. Next event PR 2.5. QRS wave 2.5. So if I ask you how long does ventricular depolarization take, literally 0.1 second, which is 2.5 small squares. Good. Yes. Okay. Right, तो पहले तीन events क्या है 0.1 second which is 2.5 squares. Last thing would be your QT interval. So QRS and T. Your QT interval is what? Starting from QRS until the end of T, right? ये जो QT interval था ये क्या interval था हमारा? Anybody wants to talk to me about it, they can. What is a QT interval? What does a QT interval represent? When I'm telling you QT interval, what am I trying to tell you? Guys? Sorry, I don't see the video. Very good. Dr. Shazib, super smart. Yeah, remember. So I'll make one thing easy for you guys to remember. When you talk about an ECG, there are three things you should talk about. There is a wave, and there is a segment, and there is an interval. Okay? Waves are what? P, Q, R, S, T. Right? These are your waves. What are your segments? You have two segments on the ECG. PR segment and what? कौन सा segment होता है और ST segment, right? Super, exactly. Interval क्या होता है? When you take a part of wave and a segment, combination of this, you get an interval. So literally, what I'm trying to say is, if you take, for example, interval बताएं, there are two intervals, right? What are the two intervals that you have? Anybody? What are the two intervals you see on an ECG? Yeah, R. I'm sorry, I didn't see the comments. PR and S. Super. PR interval? Oh, PR is an interval or a segment? Yes, RR interval, exactly. Dr. Fatma is right. RR interval hota hai, right? And guys, somebody please name the two intervals and somebody name the two segments for me. एक ST segment नहीं सुना हुआ? ST segment, right? बिल्कुल. And QT is what? QT is an interval, right? RR is an interval, very good. PR is a segment, right? So when you take a wave and a segment, you will get an interval. ठीक है? Is this clear or did I just confuse you guys? So you have waves P, Q, R, S, T, and then you have segments PR segment, ST segment, right? और जब आप wave और segment को ले लेते हैं तो you can actually come up with an interval. QT interval. QT interval will include what? It's an interval. It will include your QRS and T wave and a segment which is ST segment. तो इस सब का पूरा combination would be a QT interval, right? है ना? तो अगर if it's a QT interval, of course the time, the boxes that you're expecting would be very huge. It would not just be 0.1 second. A QT interval is 0.4 seconds. So the first activity on the ECG was 0.1 second, and then again you had a 0.1 second, and again you had a 0.1 second, and the next and the last activity, which is a QT interval, is 0.4 seconds. Who can tell me the number of small boxes that a QT interval has? Very good, Dr. Fauziya says 2 big square exactly and 10 small. Superb, exactly my point. So देखें, this is what I'm trying to say. That atrial repolarization, 2.5 boxes. Atrial repolarization, which is PR segment, 2.5 boxes, small boxes. Then QRS, again 2.5 boxes. QT interval is 10 small boxes. और इस तरह you literally solve the entire timing for your ECG. 0.1, 0.1, 0.1, and then 0.4. Yeah, simple. Oh yeah, U wave, yes. Please leave U wave. Do you know what is a U wave? Yeah, U wave happens in hypokalemia, but you can literally just have U wave. It's also normal to have a U wave. You can. When and why? Anybody knows about the papillary muscles? Yes, papillary muscles की जो contraction है, that contraction sometimes does not is not really masked by the ventricular contraction, okay, or the ventricular repolarization. So sometimes you will have what? You will have a separate U wave. So it's very normal to see a U wave in normal individuals. You can see a U wave. It's because of its papillary muscle contraction. When your papillary muscles are contracting, they produce a U wave, and it's abnormal in hypokalemia. Yes, but normal cases maybe you will have a U wave, and yes, the answer is still the same. It would still be 10 small boxes. Okay, right? Clear, guys? Super. ठीक है.
No, it's kind of smaller square boxes. Sorry, please repeat this point.
Sure. What do you want me to repeat, Dr. Fauziya?
Uh, yes, to you. You said 10 small boxes for U wave or for QT
The
interval?
entire QT interval.
Yes, not for. Okay.
Okay. Normally, you wouldn't really see a U wave because it's a part of the QT interval. It is literally the papillary muscles contracting. But sometimes, in some people, yes, you do. It becomes obvious and it's normal. So what happens is your papillary muscles contracting, but it's outside. It's falling outside the ventricular repolarization, so you might see it. But again, the QT interval would still be 0.4 seconds, which is 10 small boxes. Right? Okay. So now, when you're calculating the ventricular rate, you understand the ECG now. You know what is a big box, a small box, what to do, how to do. In UK, for example, we're just referring to UK. Why? Because the ECG moves at a speed of 25 millimeter per second. You guys see my screen, right? 25 millimeter per second, and 1 second is represented by 5 large squares. When I say a large square, I'm also saying 5 small squares. ठीक है तो why I'm telling you this because the method we use always to calculate the heart rate is depending on this. So in UK there's trying to say that 25 millimeter moves in 1 second, and 1 second is 5 large boxes. So let's write this. 20 oh, 25 millimeter moves in 1 second, and 1 second is represented by 1 second is 5 large boxes or 25 small boxes. 1 सेकेंड में 25 मिलीमीटर ECD स्ट्रिप जो है वो मूव करती है, ठीक है, और 1 सेकेंड जो है 5 लार्ज बॉक्सेस हैं और 25 स्मॉल बॉक्सेस हैं, ठीक है. I'll tell you why I'm saying this here. This is how you calculate the heart rate, and this is a very rough estimation just so you know कि आपका जो patient है is not in tachycardia or bradycardia. So what you do is that you count the cardiac cycles that occur in 6 seconds, right? Which is literally 6 seconds में you will have 30 large squares and you multiply it by 10. But let's say कि आपका जो rhythm strip है is short, you don't really have the entire strip with you. What you can do is you calculate the cardiac cycle in 3 seconds और उसको multiply कर दें 20 से. You can literally like count 3 seconds, or you can, how do you know 3 seconds? 15 large squares. How do you know 6 seconds? 30 large squares. If you have enough If you have 30 large squares, this is a 6 second strip, you multiply it by 10. If you have a small strip and you just have like 15 large squares, then you multiply by 20. Clear? Can everybody please count the नीचे वैसे आंसर लिखा हुआ है, but everybody please count the rate for this. Just try it. I can zoom in if you guys want. Kind of hard, but yeah. Are you guys with me? Who's the one who just said 310? Can I please have your name? Dr. Said. Very good. Everybody else, did you try? Yeah, if you guys have a rhythm strip, just a regular rhythm strip, please get it out and try to practice. या कोई भी Google पे लिखें, देखें, and just try to practice this concept so we can move ahead. Find out any picture and try to calculate the rate. So if your rhythm strip is big, it's a huge rhythm strip. Okay. So you literally like take 30 large squares. 30 large squares count करेंगे, उसमें देखेंगे कितने cardiac cycles हैं. You see the ये peaks. कितनी peaks हैं. Let's suppose this is my 30 large squares, for example. So I will count 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, until whatever I have, multiply by 10. This is my heart rate. Okay? Let's suppose my rhythm strip was small. I had half of the size of it needs 3 rhythm strip. Like only maybe 15 large squares. Okay? What will I do? I will count 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, multiply by 20. That's my heart rate. But in the exam, your rhythm strip is going to be like this. You will have 30 large squares. Okay? I'll give you one trick here. Do you guys see this arrow? ये arrow नजर आ रहा है ना ऊपर? ये हमेशा आएगा. Okay? This arrow occurs after every 10 large squares. ठीक है? समझ आई? ये ऊपर जो एरो है occurs after every 10 large squares. यहाँ पे कितने हैं? 3. 30 large squares की स्ट्रिप है ये. तो इसको आप जितने भी ये हेड होंगे ना 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 30, 31. 31. So you will multiply 31 into 10. Am I clear? So Dr. Said was right. Wonderful, Dr. Said. That's how you calculate. Clear, guys? Or you want me to repeat? Okay. Anybody wants me to repeat? I can. Dr. Shahzeb says it's clear. Who do we have? Dr. Anna, Dr. Obed, Kriti, Dr. Kriti, right? Okay. Okay. Right. So always look for these pointers. These are just to help you, and they will give you surely. Okay. So every pointer occurs after 10 large squares. 10 again, 10 again. This is a 6 second strip, which is 30 large boxes. Count the heads in those 30 large boxes. Multiply by 10. Let's suppose your strip was half. You only had 15 large squares, so 10 and 5 here. I will count 1, 2, 3, 4, 5, 6 and multiply by 20. It's very easy. Why am I doing this? To answer my second question, which was to know what is a ventricular rate. Why? Because if I have less than 60 or more than 100, then I know that this is a bradyarrhythmia or a tachyarrhythmia, and something has to be done about it. Okay? Because some tachyarrhythmias are so dangerous, they can actually slip into VF. And we just don't want to see a VF. The worst thing you want to see on the monitor is a VF. So anything that might lead to a VF, you want to like catch it there and resolve it. Okay, so we'll move ahead. Now, the third question is a QRS? Yeah, you can do that as well. Yeah, or you could just count the number of cycles, the cardiac cycles. This is the easiest, quickest way. Because if you sit and look count the boxes and all, it's really hard. And what you're trying to say is that would happen if you have a regular rhythm. If you don't have a regular rhythm, what are you supposed to do? Sorry, who's the doctor who just told 300 divided by boxes between 2 hour waves? Can you please give me your name so I know what to call you? Is this Dr. Saeed? Dr. Saeed, is that you? Hi. So somebody in the comment box wrote that 300 divided by boxes between 2 hour waves. Yes, that is also another method of doing it. If your heart rate is regular, if your heart rate is irregular, of course the number of boxes between the RR waves would be different. So you're not doing the right calculation, which is why what you need to do is you need to count the cardiac cycles. Easier and quicker, trust me. In the exam, you don't have enough time. Okay? And trust me, when you first see an ECG strip, you will know on spot whether this is a regular or an irregular rhythm. देख के पता चल जाता है. Don't jump, don't assume anything when you see an ECG. No assumptions, whatever. Try to find out, yes, but don't really push yourself so hard. The moment you see an ECG strip, you can literally see कि RI interval constant है या नहीं है, so it is an irregular rhythm. Then the method that Dr. Saeed wrote is not applicable. Okay. So we go next, which is the third question, which is the question Dr. Said was talking about. Is QRS rhythm regular or irregular? Okay, and how do you know this? When you measure RR interval, okay, and you keep, for example, this was it. मैंने count किया, this is my RR interval. I'll just put a mark and then I'll count this and I'll see if this of all of this falls together. So RR interval is constant. Okay, again a rough, very very rough estimate, just to know. Let's say the QRS is irregular. Okay, now when the QRS is irregular, there could be different forms of irregularity. What I'm trying to say, it could be a very irregular pattern like a VF. There is no pattern at all. You can't really identify any pattern. That's a VF, for example. Okay, or you could have an irregularity like two three good cycles and then an irregularity. It's an intermittent irregularity. Somewhere in between, some QRS activity is irregular. This is intermittent irregularity. Okay, or it could be a cyclical irregularity, like every 2 cycles and then the third is wrong, and then every two and the fourth is wrong, and then every two, and you have an irregularity. Okay, why does all of this matter? Because every irregularity has a certain condition with it, right? अगर बिल्कुल ही कोई bizarre सा pattern है, कोई recognizable pattern नहीं है, then probably you're talking about VF, right? और अगर intermittent है, maybe there's some sort of heart block. कोई cyclical है, again heart block, something. Okay, yes. So that's your third question, and the answers are just rough estimates. You just ask yourself and try to answer these questions. The fourth question, and very important question, and this actually sorts out so many things for you. Okay, is your QRS complex normal or is it prolonged? What is a normal duration of a QRS complex? Abhi, we discussed it. How long is a normal QRS complex? 2.5 small squares, which is, can you please tell me the time? 2.5 small squares, Dr. Said, is equivalent to how many seconds? 0.1, exactly. So when you're talking about a QRS complex, it should happen in literally 0.1 seconds, right? Ab, there is a QRS complex, it is 0.4. It's broad, right? It's prolonged. ये बात अपने दिमाग में ऐसे बिठाएं, just stick it, okay? Any QRS complex that is broad, it is coming from the ventricles. Any QRS complex that's narrow, it's coming from above the ventricles. और ventricles के ऊपर क्या है? SA node, AV node और your atria. Again, QRS complex, and it's a very big classification. It's a rule. ये बात आपको समझ आ जाएगी तो you will really pick up everything. QRS complex अगर narrow हो, when you see narrow complex लिखा होता है हमेशा narrow complex, narrow QRS complex tachycardia, narrow complex tachycardia, narrow complex कौन से complex? QRS complex. Narrow means what? It is coming from above the ventricles. जो electrical activity है वो QRS complex ventricle से नहीं बन रहा. It's not originating in the ventricle. There is some electrical activity outside the ventricle. It can be in the atria, in the AV node, it can be in the SA node, or it can be a supraventricular ectopic focus. ठीक है? If I say that, oh, a broad complex tachycardia, broad complex this, I'm saying that the QRS complex is more than 0.1 second. It is definitely and absolutely coming from the ventricular myocardium. Yes? Clear? Is बात को, if you guys want to, you didn't get the point. So when you look at the QRS complex, ठीक है? When you're looking at a QRS complex, you know that a normal QRS complex should be 2.5 small squares or 0.1 second, right? Ventricular depolarization happens over 0.1 second. Okay? Anything less or more is abnormal, right? When you're trying to say, let's say if you're saying that the QRS complex is 0.06, it's less than 0.1, right? It's a narrow complex QRS. Yeah, it's a very, your QRS complex is smaller than what it normally should be. There is a problem. If you are saying that the QRS complex is 0.3, again there is a problem. So if the QRS complex is narrow or it's wide, there is a problem. Okay, we need to identify where is the problem. Why is the QRS complex narrow? If a QRS complex is narrow, it means that the electrical activity, this QRS activity, is happening from a place above your ventricles. And what is the place above your ventricles? The SA node, AV node, atrium. Okay? If I'm talking about a QRS complex that's broad, that's wide, that's more than 0.1, it is because there is this rhythm is coming from the ventricles. There is a problem within the ventricles. ठीक है, क्यू आर एस कॉम्प्लेक्स हमारी ई सी जी का मेन चीज़ इसलिए बिकॉज जस्ट बाय लुकिंग एट इट यू कैन आइडेंटिफाई सो मेनी प्रॉब्लम्स. क्यू आर एस कॉम्प्लेक्स की विड्थ को देख के यू कैन एक्चुअली टेल कि ये कहाँ से आ रहा है एंड व्हाट शुड आई डू अबाउट दिस, ये रिदम कहाँ से है एंड हाउ डू आई सॉल्व इट. सो प्लीज रिमेंबर दिस, इफ द क्यू आर एस कॉम्प्लेक्स इज नैरो, by narrow I mean it's less than 2.5 boxes, it's less than 0.1. Problem is that ये जो rhythm है it's coming from above the ventricles, which can be above the ventricles is what? Atria, SA node, AV node. These could be the tissues that are firing the QRS complex. Okay? Or if the QRS complex is broad, which is more than 0.1 second, more than 2.5 boxes, this is because the ventricular activity or the rhythm is happening from within the ventricles. There is a problem in the ventricles. It's a ventricular issue. Atrial issues are different, ventricular issues are different. There is a different way to approach both of them. That's my point. तो जब आप QRS की उसकी बात करते हैं about the width, and this is a very, like, people will tell you this way, oh, this is a broad complex tachycardia, oh, there is a narrow complex tachycardia. Narrow complex is what? They're literally trying to tell you that the QRS complex is less than 2.5 boxes or less than 0.1 second, and there is a problem above the ventricles. Or if they say, oh, there is a broad complex tachycardia, they're trying to say that there is a problem in the ventricles. Yes? Clear? The next time when I say narrow complex, I'm saying atria, anything above the ventricle, or AV node or SA node above the ventricles. Or if I'm saying broad complex, I'm trying to say there is some issue with your ventricles and you need to resolve that. Right? Who isn't with me so far? Who has an issue, doubts? Please tell me. और ये 4 questions जब आप आंसर कर देते हैं कि is there any electrical activity? The 4 questions again. Sorry for dragging it for so long. Is there any electrical activity? You know the answer for it. Your second question, what is the heart rate? Is the QRS regular, irregular? And is the QRS complex normal or prolonged? In 4 questions, I mean, you have solved 80% of the problems and I will talk about it. Okay? The last 2 questions, yeah, they're important because there are some diseases with the last 2 questions and you'll get to it. So the 5th question is do you see any atrial activity? Remember, whenever Yeah, it could be narrow or broad complex barrier. Yeah, absolutely. Yes, exactly my point. Exactly. Dr. Fauci, you're right. It could be a broad complex tachycardia. When you talk about tachycardias, and I'm now going to talk about it. When you talk about tachycardia, they will tell you broad complex tachycardia. When you talk about narrow complex tachycardia, they will tell you narrow complex tachycardia. You understand me? So they're saying that there is a tachycardia, the heart rate is more than 100, and if narrow complex, there is something happening in the eight above the ventricles. Okay? Or they could be like broad complex tachycardia, they're trying to tell you there is something happening below in the ventricles. And management for broad and narrow complex tachycardias are completely different because the problem is completely different. Yeah, and I'll actually, yeah, it will only be tachycardia. Bradycardia is basically always going to be broad because bradycardia में तो conduction ही नहीं होगी. Heart blocks वो आ रहे हैं अभी, you'll understand. But remember, tachycardia is where you'll see narrow and broad. I'll just be quiet for a minute because azan हो रही है. Hi guys. Okay. So is the class too much to take? Is it boring? I'm sorry if it is, but I don't know a nicer way to talk about all of this. Okay, you guys are good and happy, alhamdulillah. Okay, 1 minute. Very good. Very good. Alhamdulillah. So the fifth question is whether you see atrial activity or not. And remember, atrial activity is one activity where you don't force yourself to see something that you don't see. अगर आपको atrial activity नजर नहीं आ रही, don't push yourself properly. It is not present, or it is there but it's being masked by something, and that's completely okay. But never assume that you see atrial activity. Never, 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 because you're going to mess up if you do that. Okay? Like if there is a P wave or there is a U wave or a T wave and that happens, sometimes it merges. There are so many escape rhythms and so many things. I'll not go into any of that because it's supposed to be a very basic class. So those things look like a P wave, but they are not P waves. So if you tell yourself, oh my god, this is a P wave, then you've really messed up. It's like you're going to catch a diagnosis but still miss it. Okay, so the take-home message is that never force yourself to see a P wave if unless and until you see it. If you really see it, it's there. If you don't see it, it's not there. Okay, and now where do you look for a P wave to really see the atrial activity? You look at two leads, which are your leads two and AVF. You can write this down, note it, and बाकी ACTs में you can just go and practice. ये सब चीज़ें of course guys you will have to practice all the things that I told you today. You will have to look at ACTs, try to identify, put it into practice. Only then it will make sense. Otherwise it will just be like okay I heard a lecture and I forgot. So practice as much as you can, and of course you will make a million mistakes, but that's okay because mistakes are what teach you, right? When I first did my ACLS in UK, I failed. I have a license for ACLS from the American Heart Society. Okay, but when I went to UK and it was like this October. I failed. I failed the practical. I was lost. It was like hyperkalemia. I wasn't giving the patient anything. I wasn't saying anything. Salman, you're not funny. So I'm like itna simple sa case, but the moment I saw the defibrillator and the pattern, I was like, what's happening? And the examiner is just looking at me, and she's the other people who were trying to simulate. They were just like, okay, what's wrong with you? Like, we are saying hyperkalemia, 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 और आप चुप है और आप कुछ कह ही नहीं रहे. Salma, I've never cheated in any of my exams. Alhamdulillah. I'm talking about UK पाकिस्तान की बात नहीं करी हूँ सलमान या सऊदी की बात नहीं करी. Very fun. Okay, guys, everybody should laugh because Salman was trying to be funny. Ha 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 ha. Salman, I'm laughing for you at your dead joke. So, atrial activity, coming back to the topic. If you don't see an atrial activity, don't force yourself to see it. Okay, where do you look for the atrial activity? In two leads, which are your leads 2 and your AVF. Okay, you know the direction of the yeah, Saudi में तो it's my Saudi colleagues I studied in Badawi यहाँ पे, they're all about money. They can buy anything with money. Man, that's all these people have. Sorry, Rosie के साथ I shouldn't be saying all of this, but yeah. So, P waves, you know that it's a positive deflection, right? Uh, as a positive deflection, of course, you'll have a positive deflection in leads to an AVF. If, of course, you'd see a negative deflection in the lead to an AVF, then you need to tell yourself that probably something is wrong here. Probably the atrial activity is not coming the right way, which is from the SA node to the atrial myocardium and then to the AV node. मेरी बात समझ आई? Like it's you know the जब हमने vector बनाया था, we made a vector which was down and right, and it was a positive charge is going towards positive charges, so our deflection was positive, right? और if and ये positive reflection आपको lead to और AVF में देखनी है, but if in lead to and AVF you don't see a positive deflection, then you're literally seeing atrial activity which is not happening the right way. Probably there's some sort of retrograde activity या कुछ और हो रहा है. We're not going into those details. All you need to remember is that lead 2 में और AVF में atrial activity is supposed to be a positive upward deflection. ठीक है, जैसे हमेशा हम पी वेव बनाते हैं वैसी होनी चाहिए. Why is my screen so blur? ठीक है. मेरी स्क्रीन ब्लर है या मेरा नेट मुझे बुरा लग रहा है. Next question and your last question finally. If you do see atrial activity blurred है right? या मुझे भी बहुत ज़्यादा blur लग रही है. Second, I think मेरा net is okay. If you do see it's better now, right? Yeah. If you do see atrial activity, do you think you need to ask yourself, is there any relation of this atrial activity to the ventricular activity? And yes, if you don't see any association, which is very common, so many conditions you don't have any association at all, and the most important of this is atrial fibrillation. कोई किसी के साथ लेना देना ही नहीं है. Third degree heart block लेना देना ही नहीं है. So then again you see every question has a different case that you can answer or you can address. So of course the atrial activity should be followed by ventricular activity. P wave should be followed by a QRS complex, and if you see a P wave followed by a QRS complex, you're trying to tell yourself that your heart's atrial depolarization is normal and regular, and the ventricular depolarization is normal and regular, and everything is good. But if the atrial activity is not followed by a QRS complex, then probably there is an issue. Okay. Yes, because we're done with our questions. And if there is know if they are not related, then you need to ask yourself how are they not related. I've just put up all this information so you guys can read. जब आप पढ़ेंगे इस PPT को, you will really have a lot of information. It will help you actually. मैं बस basic से समझा रही हूँ. तो हमेशा atrial activity should be followed by ventricular activity. If there is no association which happens in a number of conditions, especially heart blocks में, तो it is okay. यानी there is some sort of abnormality, but you need to ask yourself कि क्यों नहीं है related और कैसे related नहीं. Just turn on the AC. So, अगर रिलेटेड नहीं है एट्रियल और वेंट्रिकुलर एक्टिविटी, देन व्हाट्स हैपनिंग, कैसे रिलेटेड नहीं है, व्हाट्स मिसिंग, कितने पी वेव्स हैं और कितने क्यू आर एस नहीं हैं या कितने क्यू आर एस मिस हैं, ये सब चीज़ें. ओके, very good. So we are done with the 6 questions. Number 1 was, is there any electrical activity? Number 2, what is the QRS rate or what is your heart rate? Is the QRS regular or not? Fifth question, electrical activity, heart rate, QRS regular or not? I forgot. Um, uh, yeah, so the width, oh my god, this is the most important question. QRS complex की width normal है या it's prolonged, it's a broad or a narrow complex, और atrial activity है या नहीं, और अगर atrial activity है तो how does it relate to your ventricular activity. ठीक है. Now, cardiac arrest rhythms जो होते हैं, there are 3 things, and those 3 things we already spoke about most of them. हमने literally सारे चीज़ों के बारे में बात कर ली, but I'll just go into more details now जो SMLE में वो पूछते हैं. ठीक है. Number 1 thing is ventricular fibrillation. That's the worst rhythm you can ever wish to see. Okay, it's an emergency. It's horrible. देखते ही पता चल जाता है कि this is a ventricular fibrillation on spot. ठीक है, तो examiners love it. अगर आपको मिल जाए तो it's well and good because it's a very easy rhythm to identify. Second is asystole, easiest one to identify. You know what to do. Nothing. Just pray for the patient because he's gone. And PE, pulses electrical activity, PEA. Yes, like I told you कि electrical activity है, but इस electrical activity को you cannot say whether this is a VF, whether this is a SVT, whether this is AF, को हम किसी उसको categorize नहीं कर सकते इस electrical activity को. And there is no pulse. So what you will do is, the moment you see no pulse, CPR. No pulse is equivalent to starting the CPR ASAP. Okay, and once you start doing CPR, you will start seeing a rhythm on the screen. You will start seeing either वो VF बन जाएगा, AF बन जाएगा, SVT, कुछ भी, but कुछ हो जाएगा. And probably inshallah you'll be able to save the patient. ठीक है. So 3 चीज़ें हैं that you need to really focus on. Number 1 is your ventricular fibrillation, and I'll talk about it अभी. asystole हमने already बात की, simplest one. And PEA, कोई भी identifiable rhythm नहीं है. rhythm electrical activity है, but rhythm क्या है हम बोल नहीं सकते, और कोई pulse नहीं है. So CPR. Next, asystole, we spoke about it. It's good. सही है. We said कि अगर finds ventricular fibrillation, I was saying that ventricular fibrillation can be coarse or it can be fine, right? Sometimes fine ventricular fibrillation presents like asystole. तो आप CPR करेंगे तो वो उसका जो amplitude है वो बढ़ जाएगा, and you will be able to see like okay, this is not an asystole, this is a VF. Might of course go into an asystole, but this is one thing जो asystole के साथ थोड़ा सा clinically confuse होता है कि asystole या simple asystole हो सकता है, or it can be a fine VF. How to be sure कि this is a fine VF and not an asystole? Because अगर fine VF is still the patient is, there is chances you can save the patient. So you do CPR, और आपके जो mechanical chest compressions होते हैं और breathing होती है, उससे you can actually increase the amplitude of your wave, और उससे आइडेंटिफाई हो जाएगा कि जी ओके दिस वाज अ फाइन VF, और फिर हमें उसको ट्रीट कैसे करना है. ठीक है. Yes, because if it's a fine VF, आप defibrilize करें, defibrillator लगाएं, तो you actually have a chance to bring back the patient. लेकिन asystole में तो like I said, defibrillator लगा ही नहीं सकते because that's it, the patient is gone. Okay. Then pulseless electrical activity, no specific rhythm. You can't say this is a certain condition, but and there is no pulse. All you can do is do a CPR and try to make sure that the rhythm comes back to some identifiable rhythm. And when can you have pulseless electrical activity? Good point. I want to mention this. For example, in pulmonary embolism, tension pneumothorax, cardiac tamponade, or acute severe blood loss, these are conditions. So if you in this time you see any of this, then probably you are looking at a pulseless electrical activity. ठीक है, बट ये आता नहीं है, ये क्लिनिकली तो आपको ऑस्की में आ जाए शायद, मुझे आया था, बट आपको थ्योरी में नहीं आ सकता बिकॉज देर इज़ नो रिदम दैट यू कैन सी. Okay. Then you talk about ventricular fibrillation, and this you have to keep in your mind. A person who has ventricular fibrillation is not going to be talking to you. The person with ventricular fibrillation is not conscious. So that person, if you see a person awake, if you see a person talking to you, if you see a pulse, you are not seeing ventricular fibrillation, and this is a rule. ठीक है. Now let's say आपने ventricular fibrillation देख लिया है, and you know this is a ventricular fibrillation, you have to, it's a shockable rhythm, you have to go and shock right there. No wasting time. Okay? इसीलिए we want to identify ventricular fibrillation as soon as we can, because we catch it and just that's it, we go ahead and we just shock it. And this is the easiest to identify. देखते पता चल जाता है, तो आपको ये जो 6 क्वेश्चन हैं ये पूछने की भी जरूरत नहीं है खुद से. You know this is VR. Okay. Next is ventricular tachycardia. So ventricular fibrillation is something, and ventricular tachycardia is something. From the name ventricular tachycardia, your ventricles are beating too fast. Okay, right? और ventricular tachycardia में बहुत चीज़ें हैं that you need to talk about. It could be a monomorphic. Morph होता है shape. Morph is Latin for shape. Mono is one. So your ventricular tachycardia का जो rhythm है, it's one sort of rhythm. Or it could be a polymorphic. Oh, hello. एक second. I think it's because I turned on the AC. Is it better now? Yes. So ventricular fibrillation is something and ventricular tachycardia is something, right? Ventricular fibrillation हमें समझ आ गई, right? Now talking about ventricular tachycardia. A ventricular tachycardia patient is alive. He's awake. He might be talking to you. Okay. He will have a pulse inshallah, right? ये ventricular tachycardia. From the name, the ventricles are beating too fast. ठीक है? And you can expect a rate of 100 to 300 beats per minute. सही है. और ventricular tachycardia के different, like when you see the strip for ventricular tachycardia, the rhythm can be so many different forms, like monomorphic or polymorphic. Morph is Latin for shape. जी, I will come to SVT and VT. SVT का proper हमने बात करनी है because SVT is one of the most important ECG strips for SMLE. वो इसके बाद मैं बताती हूँ. So when we talk about ventricular tachycardia, the rate is 100 to 300 beats per minute. सही है. And the shape can be polymorphic or monomorphic. Morph, and for Latin means Latin may morph is basically shape. Mono is one. So monomorphic is when your ventricular tachycardia rhythm looks alike. Okay. And polymorphic is when it looks bizarre. It's different. It's different shapes. And I'll go to that a bit. What else? So when you're having a ventricular tachycardia, would you expect to see atrial activity? A person with ventricular tachycardia, can they have atrial activity? Yes, of course, yeah. They will have atrial activity, wonderful. But do you think that the atrial activity जो है, yes, exactly, Dr. Faucia, it would be must. It would be like a dissociative pattern. कोई pattern नहीं है. मतलब you would see a P wave and a QRS, too many QRSs, not see a P wave, it's okay. But there is atrial activity, but not really. हमारा जो last question था कि is it linked to ventricular activity? No. ठीक है? Because the ventricles are beating too fast. और जहाँ पे आप ये देख लें कि there is a ventricular tachycardia and it's not really relating to a P wave, this is ventricular tachycardia for sure. जहाँ पे आप देख लें कि there is a broad complex tachycardia, broad complex मैं बोल रही हूँ, broad complex इसलिए बोल रही हूँ ताकि आपको पता चल जाए this is from the ventricles. तो जहाँ पे आप देख लें कि there is a broad complex tachycardia and उसका कोई लेना देना नहीं है P waves के साथ, कभी है कभी नहीं, this is ventricular tachycardia until proven otherwise. Yes, you guys can write this if you want. So if you see a broad complex tachycardia, broad का मतलब क्या? More than 2.5 boxes, more than 0.1 second. अगर आपका QRS complex है और वो उसका QRS का P से कोई लेना देना नहीं है, this is VT, ventricular tachycardia. Ventricular tachycardia, patient is still alive, he's awake, he has a pulse, but of course he's not feeling well enough, you have to be very careful with ventricular tachycardia because the chances of it becoming a pulseless ventricular tachycardia or becoming a VF is very high. ठीक है. So if patient with ventricular tachycardia becomes pulseless, again you have to treat it like VF. वो ventricular fibrillation ही बन गया. So you have to start defibrillation. सही. Yes. Why is ventricular tachycardia hard? Why is it difficult? Because the ventricles are beating so fast, उनको cardiac output कोई आ ही नहीं रहा. Patient is really like sick and stuff, and it might become a VF. So you have to be careful. You have to be watchful. You have to like act quickly. Yeah. Okay. Great. See, this is a ventricular tachycardia. Let's ask yourself those 6 questions. Do you see electrical activity? Yes. What is a heart rate? Of course, there is a tachycardia. तो देख के पता चला. You don't even have to count the boxes. पता चल रहा है, right? That it's a tachycardia. Yeah. Third question क्या था? QRS क्या? First, electrical activity है या नहीं है? Second question was what is the heart rate? Third question was, guys, talk. Hello, people. So the first question was, is there any electrical activity? Yes, there is electrical activity. What next? What is the heart rate? This is a tachycardia. QRS rhythm regular है, irregular है? So and so. It's kinda, yeah, regular or irregular, yeah. Kinda regular, looks regular, exactly. What is the QRS width? Is it normal or is it broad? Yeah, very good, Dr. Yusra. Is it normal or is it broad? It's wide, exactly. It's wide, superb. It's wide, right? Do you see any atrial activity? No P wave, no. एंड तो अभी सो वी सेड अभी हम क्या कहें टैकीकार्डिया पहला एक सवाल पहला आंसर हमें मिल गया टैकीकार्डिया है इट्स वाइड मतलब इट्स वेंट्रिकुलर हमने कहा नो पी वेव सो व्हाट डू वी हैव वेंट्रिकुलर टैकीकार्डिया broad complex tachycardia which has no association with the P wave is ventricular tachycardia until proven otherwise, right? Exactly. Broad QRS complex, no P wave, no association with P. कोई है ही नहीं P, कोई लेना देना नहीं है P के साथ. This is a ventricular tachycardia. बात मैंने आपको ये समझानी है इस वर्ड की मोनोमॉर्फिक. ये जो सारी वेव्स हैं एक जैसी लग रही हैं, राइट? ये तो नहीं है ना कि कोई बड़ी है छोटी है. नो, इट्स ऑल द सेम, राइट? इफ यू कंपेयर दिस टू दिस, है ना फर्क? You see the difference? It's big and then small and then big and then small, right? This is polymorphic. ये मैं कह रही थी कि ventricular tachycardia के दो क्लासिफिकेशंस होती हैं, मोनोमॉर्फिक और polymorphic. And this is a French word, or say I'd say points. I'm not even going to pronounce it. And you guys know what this is because of? There is a problem with something is decreased, which is your magnesium, and that is what causes a polymorphic ventricular tachycardia. Right? Good? Easy? अगर आपको वो ये दे दें, how to differentiate between VT and VF? ओहो डॉक्टर शाहजेब, ओए होए, आपने तो मुझसे फिर से स्टार्ट करने का कह दिया लेक्चर. So VF. I'll show you a VF and then I'll let you answer that question yourself. डॉक्टर शाहजेब आप तो बस शहजादे बंदे. ये देखें, ये VF है, सही है? इसे गौर से देखें. दिस इज अ VF, ऑल्सो अ VF. ठीक है, अब मैं आपको दिखा रही हूँ जो. अब आप आए ventricular tachycardia. You see it? Still have the same question. How to differentiate between VT and VF? Yes. आ गई ना समझ? VT तो बहुत ही फिर भी लाइक कुछ समझ आ रही है, कुछ है. There is something. Even a polymorphic VT still makes sense, but VF, it doesn't make any sense at all. That's really, 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 yeah. VF तो देखते ही पता चलता है कि ये VF है. You don't even have to think about it. You just know this is a VF. एक atrial flutter और एक VF. It's on spot diagnosis. और VF तो होना भी on spot चाहिए, वरना you are gone and the patient is of course gone. Okay? When nothing makes sense, it's a VF. And if something still makes sense and you answer those 6 questions, a broad, complex tachycardia with no association, no P waves association, then that is a VT. ठीक है. और VT की भी दो classifications हैं, fine and coarse, but not really important. But you still know it now. ठीक है. Okay, किसी ने मुझसे वॉल्फ पार्किंसन वाइट सिंड्रोम का पूछा था. Now there are two things that resemble a VF. Astaghfirullah. Okay. VF is this creepy thing, the creepiest pattern you have. Two things, which is polymorphic VT जो कि हमने देख लिया. This is somewhat resembles a VF. थोड़ा थोड़ा, लेकिन इतना नहीं, फिर भी थोड़ी सेंस बनती है. So this is a polymorphic ventricular tachycardia, VT. This is VT. Okay. Another thing that looks like a VF but is not a VF is an AF. Okay. Yes, guys, you understand? So polymorphic VT हमने कर लिया. It looks like a VF, but it's not VF. Then pre-excited AF. Oh my god. The name is so scary. This is atrial fibrillation. Please focus. Atrial fibrillation. Pre-excited atrial fibrillation resembles a VF. सही है? And the other name for this is Wolff Parkinson White syndrome. Just a second. My mama wants me. Guys, 1 minute. अम्मी बुला रही हैं. Okay. Can you guys still see my screen? Oh. Yeah, ठीक है. So a pre-excited AF is literally Wolff Parkinson White syndrome. ठीक है. उसमें क्या हो रहा है, I'll tell you. I told you कि मैं आप लोगों को समझाया हुआ है कि if this is your atria and your ventricle, हमेशा SA node, ये atria है, ये ventricle है, this is the AV node. Activity comes from the SA node to the AV node, right? Wolff Parkinson White syndrome में क्या होता है कि there are accessory pathways. यानी एक्टिविटी सिर्फ यहाँ से नहीं आ रही, एक पाथवे से नहीं आ रही. देयर आर अदर कनेक्शंस एज वेल बिटवीन द एट्रिया एंड द वेंट्रिकल. ठीक है. उससे क्या होता है कि एक जो लाइक तरीके से एक्टिविटी ऐसे नोड से एवी नोड आती है और एक साथ सारे कॉन्ट्रैक्शन होता है, दैट इज़न्ट रियली पॉसिबल. सारी एकदम से एक्टिविटी, करंट यहाँ से भी आ रहा है, यहाँ से भी आ रहा है, वहाँ से भी आ रहा है. सो बहुत ही अब्नॉर्मल सी अजीब सी एक पिक्चर है. And that causes the ventricles to beat like really, really, really fast, like 300 beats per minute. And so you have something which is an AF, but it resembles a VF. Easy या नहीं? और मुझसे किसी ने सवाल किया था कि वॉल्फ पार्किंसन वाइट syndrome. Yes, you did. Doctor said that was you, I think. Will it be a broad complex or a narrow complex tachycardia? I'm talking about ventricular tachycardia. I'm talking about मेरी बात सुने. I'm talking about ventricular tachycardia. Yes, it's a broad complex tachycardia. Exactly. Yeah, so it's a broad complex tachycardia. No, it's a broad complex tachycardia. Because I'm talking about, I just said कि accessory pathways हैं, वो pathways जो हैं वो जो आपकी atrial activity को इतना जल्दी impulses भेजते हैं. Wolff Parkinson White syndrome is a broad complex tachycardia. Why? Because your atria is really firing the impulses so fast to the ventricles. The ventricles जो हैं, they go into tachycardia. They beat really, really fast, like 300 beats per minute. I'm again saying ventricular tachycardia. Ventricular tachycardia is broad complex tachycardia. जब मैं ventricle की बात करूँ, it's supposed to be a broad complex tachycardia, and you can read this here. Do you guys read this? Produces a irregular broad, irregular because कोई pattern ही नहीं है. Broad complex tachycardia. Why broad complex? Because ventricular tachycardia की बात कर रहे हैं. Okay. डॉक्टर सईद, are you with me? Do you understand my point? जब भी हम ventricular tachycardia की बात करें, ventricular tachycardia is broad complex tachycardia. Yes? Does everybody understand? बिल्कुल. That's right. That's right. Yeah. Okay. Yes, you have a point. But what is in tachycardia? Conduction pathways हैं, but what are they making the... No, नहीं, जो connection pathways, yes, they are abnormal connections. I didn't say they're coming right from the atria. Abnormal connections आ तो रहे हैं, but they're causing a problem in the ventricles, right? है ना? Problem ventricles में, right? Is it causing atrial tachycardia or ventricular tachycardia? Ventricular tachycardia, right? The problem is in the ventricles. Problem अगर ventricle में हो, so it's a broad complex tachycardia. Do you understand me? इसको बहुत simply से, like it's a very simple explanation कि अगर सलमान, you would like to speak, आप बोल सकते हैं.
बस मैं ये कहना चाह रहा था कि ऑलमोस्ट 2 घंटे से क्लास हो रही है, तो हम नेक्स्ट ना सेकंड में कर लेंगे. काफ़ी लोग घबरा ना जाए. नहीं, घबरा ना जाए, क्योंकि जितना इन्होंने पढ़ा है उतना वो ये रिवाइज कर लें, उतनी समझ लें. कोई रश नहीं है. नेक्स्ट हम दूसरी सेकंड क्लास में कर लेंगे.
Guys, if this is what you want, okay, I have no problem. ठीक है, बट सलमान, मैं बस ये ख़त्म कर लूँ. Guys, okay, let's just finish this. So you have accessory pathways या bypass tracks. उससे क्या होता है कि the electrical activity goes from the atria to the ventricles, okay, and it has somehow bypass your AV node. AV node से भी थोड़ी सी आ रही होती है, but not too much. Mostly वो बाकी जो accessory pathways हैं, they're so quick कि before AV node में, you know, I told you guys that AV node is a very slow and a very small tissue. तो वहाँ पे बहुत ज़्यादा delay होता है, और वो delay अल्लाह ताला ने किसी वजह से रखा है. And you guys know the reason, ताकि ventricular complete filling हो सके before the ventricles go into depolarization या contraction. ठीक है? तो जो accessory pathways हैं, unfortunately they are much more active than the SA node to AV node वाला pathway, and so this causes the ventricles to contract really fast and go into tachycardia. और इस tachycardia को you need to identify, because again ventricular tachycardia can always become a VF. Okay? Yes? Understand? Okay. Anything else I wanted to say here? Okay, so when you see, I think, Salman, how many questions do we have from in ECG? Okay, you want me to repeat? Oh, my voice is not clear because of the AC. Right, so Wolf Parkinson, ये हम दो conditions की बात करते हैं, polymorphic VT which resembles a VF, and we have a pre-excited AF which is a Wolf Parkinson White syndrome. ठीक है? Polymorphic VT was this, and yes, it does resemble a VF. The next thing is a pre-excited AF which is Wolf Parkinson White syndrome. और इसमें क्या होता है कि नॉर्मली एट्रियल जो इलेक्ट्रिकल एक्टिविटी है हार्ट की, इट शुड गो फ्रॉम द SA नोड टू योर AV नोड, बट यहाँ से सीधी एक्टिविटी नीचे आनी चाहिए थी, बट इट डजंट. व्हाई? बिकॉज देयर आर सम अदर एक्सेसरी पाथवेज, और जो इलेक्ट्रिकल एक्टिविटी है वो SA नोड से डायरेक्टली यहाँ पे आने की बजाय इट्स कमिंग फ्रॉम द अदर पाथवेज एज वेल, and that causes the ventricles to contract super fast, like 300 beats per minute or more. Okay, because this is a ventricular tachycardia, we call it is an irregular broad complex tachycardia, and this is why it resembles a VF. Okay, Yes, makes sense. Dr. Shazib, is it clear for you now? मैं Dr. Shazib, yes, Dr. Shazib. Okay, Dr. Shazib, that's wonderful. जब भी I'll repeat this again inshallah next class में, जब भी आप वॉल्फ पार्किंसन को देखते हैं, please just look at delta wave. The moment you see a delta wave, it's just there. It can be inverted, positive deflection doesn't matter. Positive, negative deflection, it's okay. As far as you see one, this is Wolf Parkinson White syndrome. I know थोड़ा सा नहीं है इतना ये clear. I'll speak about it again. उसकी tension मत लें. But delta waves are representative of your Wolf Parkinson White syndrome, which is an AF, which is causing a VF, which resembles a VF. An AF causing a ventricular tachycardia that resembles a VF. यही कहना है, ठीक है? Right? Okay, now this peri-arrest arrhythmias, this is now talking about bradycardia and tachycardia. Again, if you guys want me to explain, I can. One of we'll put this for the next class. We still have a lot to do. हमने कर लिया है, but like see, it's just repetition, but yeah. Yeah, delta wave. Yes, Dr. Shazib is supposed to be involved Parkinson White syndrome. आपको delta wave देखनी है, I can show it to you. Here, this is a delta S, a cone. Right? You see the delta wave, it can be inverted as well. This is what I was saying, it can be inverted. Or it can be a positive deflection, negative deflection, but if you see this, you're seeing a delta wave. And if you see a delta wave, you're seeing looking at Wolf Parkinson White syndrome, probably nahi aayega, but still just keep it in mind because one of the ECGs is about Wolf Parkinson White syndrome. जी वो इस तरह अपीयर होती है डेल्टा वेव आफ्टर द पी एंड बिटवीन द क्यू आर एस के क्यू आर एस जो है वो डेल्टा साइन बना होता है यू गाइस सी ये देखें दिस इज योर पी ये आपका क्यू आर एस और दिस इज योर डेल्टा या सिंपल again delta okay guys Salman do you want to end the class जी I will actually Dr. Shazib I'll put this again for the next class we'll postpone this and we'll come back to this again यहीं से start करेंगे इंशाल्लाह maybe we can arrange the next class in 3 days Friday को ले लेते हैं if you guys want after Eid okay I have no problem I will still send you guys a PPT so you guys can start reading and then I'll explain Brady and Taki and all of these are fun ये तो बहुत ही simple से हैं हमने ऑलमोस्ट कर लिए हैं बट आई जस्ट स्टिल वांट टू एलैबोरेट अ बिट सी ब्रॉड कॉम्प्लेक्स टैकीकार्डिया जो हम बात कर रहे थे किसी ने मुझसे ये सवाल नहीं पूछा कि ब्रॉड कॉम्प्लेक्स और नैरो कॉम्प्लेक्स बिकॉज ऑफ कोर्स मे बी अभी मैं नैरो कॉम्प्लेक्स में आई नहीं हूँ बट व्हेन आई कम टू नैरो कॉम्प्लेक्स टैकीकार्डिया यू विल आस्क मी कि हाउ डू यू डिफरेंशिएट बिटवीन अ नैरो एंड अ ब्रॉड कॉम्प्लेक्स टैकीकार्डिया तो दिस इज़ अ वेरी गुड मेथड ऑफ आइडेंटिफाइंग कि कैसे पता चलता है कि ये वेंट्रिकुलर जगह से आ रहा है या एट्रियल से आ रहा है इट्स अ रूल इट्स अ क्राइटेरिया and then I think Dr. Said आपको भी clear हो जाएगा why Wolff Parkinson is a broad complex tachycardia.